Hello, and welcome to the Clinical Care Options Oncology Podcast. I'm your host, Tim Quill. Today's episode features Dr. Jame Abraham from the Cleveland Clinic in Cleveland, Ohio, Dr. William Gradishar from the Robert H. Lurie Comprehensive Cancer Center in Chicago, and Dr. Laura Spring from the Mass General Hospital Cancer Center in Boston, Massachusetts. They will be providing their insights on the latest evidence and clinical pearls related to the use of CDK4/6 inhibitors for patients with early and advanced HR-positive, HER2-negative breast cancers. This episode is part of a larger educational program titled Experts Debate and Discuss Therapeutic Strategies Using CDK4/6 Inhibitors Across Breast Cancer. For more information on our presenters, along with a link to the larger educational program, please visit the show notes for this episode. Now let's get started and hear what the experts have to say.
So what I'm going to talk about is some of the advances in adjuvant therapy and how we're applying those to patients with hormone receptor positive HER2 negative breast cancer. I think that as some, sort of a 10,000 foot view of things, we're not going to get way into the weeds, but I think we all recognize that there are certain clinical features that correlate with the patient being considered high risk. Tumor size, nodal status, high grade, all affecting risk of recurrence. And these features also can play into the accuracy of gene expression profiling. We also know that higher Ki67 and index of proliferation and low ER levels increase the risk of recurrence. And it also corresponds to the activity of preoperative endocrine therapy. We've seen, particularly from the Germans who have done a lot of work in this area, that if you're able to suppress Ki67 or not, it may be an indicator of your likelihood of benefiting from adjuvant endocrine therapy. And we also know that certain gene expression profile subtypes, such as luminal B or HER2 enriched or basal-like, are high-risk hormone receptor positive HER2 negative breast cancer. And we often rely on clinical parameters to make the decision on what they actually are, but oftentimes you have to use some gene expression profiles to be absolutely confident. So one of the things that we all acknowledge, and we face this in the metastatic disease setting, is that endocrine therapy eventually stops working. Patients become resistant to it. And there are a number of new drugs that have been introduced in that setting that are helping us manage those patients after they develop disease progression. But this can also happen in the adjuvant setting, and this highlights a patient who may have intrinsic resistance as well. So if you look at the 2022 ASCO guidelines and how we apply some of the biomarkers we have available for making decisions regarding hormone receptor positive HER2 negative breast cancer, you could broadly separate the groups into those that are premenopausal and postmenopausal. If you look at premenopausal women with respect to their nodal status and look at the node-negative patients, we rely oftentimes on the 21 gene recurrence score to make decisions about whether chemotherapy would offer any additional benefit, in addition to its prognostic as a prognostic tool. In premenopausal women who are node positive, the RxPONDER trial suggested that we still don't have absolute confidence that we can avoid using chemotherapy in that group, even those with lower nodal burden. We, of course, have always attributed some of the effect of chemotherapy as ovarian ablation. And, of course, we're addressing that now with a trial referred to as the OFFSET trial. In the postmenopausal group of women and node-negative patients, we have a number of different tools that clearly have shown that you can get prognostic information about patients. I think it could be argued whether we have many of those that are actually predictive of the benefit from chemotherapy. Oncotype has certainly fallen into that group. Mammaprint, it's often argued whether it's predictive and prognostic. And then the others that are listed there are certainly prognostic. For node-positive patients with 1 to 3 lower nodal burden disease, we can rely on the Oncotype. And then again, we have prognostic information from the others. And for those with higher nodal burden, we don't really have any tool that we can confidently use that allows us to avoid using chemotherapy in that group. All right, so if you think about, again, 10,000 foot view of things, if you have somebody who undergoes surgery and they have a T1 through 3, N0 to 3 tumor, These are oftentimes viewed as patients that could have a higher risk of recurrence. The first decision point is what can they tolerate to reduce their risk? So if you're going to optimally treat them, if they have a high risk, chemotherapy might be part of the plan. You may optimize their endocrine therapy, as we'll be talking about in a moment, with the addition of CDK4/6 inhibitors. So you have to understand and think about whether or not the patient can tolerate or abide by the treatment recommendations. And if not, then probably you're thinking about somebody who's more frail and would be considered for single agent endocrine therapy. But if the patient has a high risk of recurrence, then of course the thought of chemotherapy either in the neoadjuvant setting, prior to surgery or postoperatively, comes into play. And then of course you have to assess their eligibility for trials that would include a CDK4/6 inhibitor based on monarch-E and NATALEE trial. And then it should never be forgotten, of course, that a not insignificant number of patients who are ER positive can harbor germline mutations. So I think it's a relevant question to consider whether or not the patient may be eligible for a PARP inhibitor. So these are all the factors, among others, that come into play when you're making a decision. So if you put the monarch-E and NATALEE populations next to each other, first of all, the NATALEE population included node-negative patients, which I think is sort of one of the take-home messages you all appreciate from when that data was presented, in contrast to the monarch-E trial, which did not include node-negative patients. For those patients who were node-negative in the NATALEE trial, it wasn't just any node-negative patients. They'd have a higher grade disease or high Ki-67 or a high genomic risk based on a test like Oncotype or MammaPrint or Prosigna. And again, the same features would have been applied to patients in monarch-E. So again, you have to think about what the eligibility were for each of those trials and whether your patient fits that. And then, of course, if they had a germline mutation, how do you make a decision about either utilizing a PARP inhibitor or a CDK4/6 inhibitor, or actually both, depending on risk? So if you look at the monarch-E, the primary endpoint of invasive disease-free survival at 5 years, there is a separation of the curves. And one of the satisfying things about this data set over time is it hasn't come back together, but actually separated to a greater degree. So as we've gone out with longer follow-up, the separation between the curves is approaching 8%. So there is a difference that would favor utilizing absicillib in the population that was eligible in this trial. In the NATALEE data set, now at the 4-year landmark analysis, the DFS is also looking similar. I don't think I mentioned it, but I think you all are aware that with monarch-E, it was 2 years of abema, 3 years of ribo with NATALEE. If you look at the populations in NATALEE, there were node-negative patients as already described. Again, there is a separation between the curves, and the delta at this point is about 5%. So for those higher risk node-negative patients who would have been eligible for this trial, the NATALEE data set supports using ribociclib in this setting. And then for the node-positive patients, there's a delta of about 5%. And with the passage of time and more events, we're seeing that that delta is expanded as well. So I guess one of the questions that comes through is the obvious one. And for a patient who could be eligible for both monarch-E and NATALEE, how do you decide? Laura.
Sure. So I think it's great that we have two options. I like to discuss both drugs, the data, as you mentioned, we have longer follow-up with abemaciclib and the different side effect profiles as well. There may be some specific patient factors that make someone favor one over the other, but ultimately it's nice that, if we do start with one, if it doesn't go well, that we do now have an alternative option.
Does the duration of therapy sway you one way or another when you're thinking about that, or is it you want to see how they tolerate it before?
I think more so tolerability, but I do think that is a factor for some patients. I have had some patients ask, can I do ribo after abema, or could I do abema for 3 years? We just don't have that data.
Okay. And then, Jame, the question about ovarian suppression, particularly in the younger patient, one, would you have started that before chemotherapy or concurrently with chemotherapy, or just started afterwards?
So that's a good question. That depends. And let's just say if you're trying to have fertility preservation, and then of course we will start that before or during the chemotherapy. If the fertility preservation is not an issue, usually I start after I'm having a conversation about adjuvant treatment. Is that the same way you do, or?
Yeah, and I guess one of the other issues, if it was a really young patient too, if you were trying to use the ovarian suppression in any way to maybe preserve ovarian function for some later time point for fertility issues too. Laura, you have any different approach to that?
Yeah, no, I approach it the same way.
Okay. And then we know that in the metastatic disease setting with ribociclib, the pivotal trials started at a higher dose compared to the adjuvant setting where it was 600 to 400. So does that give you pause in using a different dose than we saw in the metastatic trials? Part of it was tolerability. Part of it was they thought you could give it longer at a lower dose.
Yeah, I think we saw in the advanced setting that dose reductions, when appropriate, were not harmful, when it came to efficacy, which is also what we saw in the early breast cancer setting. So I do think it's helpful. I think, not so much from a hepatotoxicity standpoint, but I think certainly lower rates of issues with QTC prolongation and fatigue counts as well. So I do think it's, helping quite a bit from a tolerability perspective.
So probably the last question before we move on, it is an attractive idea. What's unique about HER2 positive disease that happens to be ER positive and at high risk? So the trials in the adjuvant setting purposely excluded HER2 positive disease. But is there any data to support the use of a CDK4/6 inhibitor in that population, either with HER2 directed therapy or after?
So that's a really good question. In the adjuvant setting, as you said, we don't have much data. And that's one of the subset of patients I may use extended adjuvant HER2 blockade with neratinib, one of those agents. So that's the data we have, and that's what I made.
Okay. Anything different?
Yeah, I think of some one-off kind of challenging cases where perhaps, I have one situation with a bilateral breast cancer, one being a high-risk HR positive, HER2 negative, the other side being a HER2 positive. So then you have to think a lot about sequencing of therapies there, but I have run into that particular situation.
So we're going to talk about how do we optimize a treatment in hormone receptor positive, HER2 negative metastatic breast cancer. So how potentially we can treat a patient with metastatic breast cancer. If the patient has recurrence while on adjuvant AI or recurrence less than 12 months since the completion of AI completion, it's fulvestrant plus ribociclib or another alternate CDK4/6 inhibitor. Based upon some of this new data, NGS testing is moving up to on a first line if the recurrence happens, especially if the recurrence happens while on adjuvant AI for less than 12 months since the completion of AI. And potentially those patients can be treated with the EPIC3 inhibitor, palbociclib and fulvestrant. So CDK4/6 inhibitor in first line setting. So all trials consistently showed the same finding, doubling of progression-free survival in first line metastatic breast cancer. So in general, I say about a year with endocrine treatment only, and then when we use endocrine treatment plus CDK4/6, it's about 2 years. So that's consistent across with all the CDK4/6 inhibitors, including palbociclib. But ribociclib showed an improvement in overall survival with postmenopausal setting, with fulvestrant, and in perimenopausal setting. So that's the difference between these three agents. Ribo is only one, which showed that survival advantage. The right choice looked at role of ribociclib plus endocrine treatment versus standard chemotherapy in patients with aggressive disease with no previous systemic treatment. In general, chemotherapy in first-line setting, roughly 9 to 12 months, but when we use endocrine treatment plus CDK4/6, it's almost 2 years. So even though the patient has more aggressive disease, if the patient is not in a classical visceral crisis, we should be considering endocrine treatment with CDK4/6 agent. The SONIA trial is an interesting trial which looked at role of upfront CDK4/6 inhibitor versus sequencing CDK4/6 inhibitor. There was no difference in using sequencing versus using upfront. But this is really nice study, which they actually looked at financial toxicity, especially in different systems where patients have to pay out of pocket. So they showed there was no difference in sequencing the CDK4/6 rather than starting it upfront. So moving on to the next clinical scenario, let's just say if the recurrence is happening while on AI or less than 12 months since the AI completion. So that patient's a little more refractory, resistant to an aromatase inhibitor. For that patient, definitely, and I think we should consider doing an NGS testing, looking for potential genomic targets such as PIK3 or ESR1. So in our trial, which actually looked at Innova plus Palbo plus fulvestrant for PIK3 mutated recurrent metastatic breast cancer, with the primary endpoint of progression-free survival. The Innova dose is 9 milligram daily, 1 to 28. Palbociclib is the standard dose, 125 milligram a day, 1 to 21 days, plus fulvestrant every 4 weeks. So the progression-free survival doubled and from 7.3 to 15 months when the patients received Innova in addition to Palbo and fulvestrant in PIK3 mutated patients. Side effects are kind of expected for a PIK3 inhibitor, slightly more neutropenia, thrombocytopenia is clearly more, and then mucositis is more, and then this subset of patients, and more of anemia in these patients. Hypoglycemia was also seen, kind of a target effect. Other GI side effects such as diarrhea, nausea, and then rash are those seen in patients with thin. If the NGS testing is showing a PIK3 mutation, it's very reasonable to treat the patient with a PIK3 inhibitor. So let's just say if the patient is progressing beyond that, the first line of treatment, then of course we keep looking for ESR1 mutation, and then of course the PIK3 mutation. And there are a number of options beyond the first line on a setting what we just discussed. So elasticin is one of the agents for ESR1 mutated. Of course, we have fulvestrant and CAPI for patients with PIK3 AKT or PTEN alteration. So ER-positive HER2 negative patients with these mutations, as we discussed, we can use Innova plus Palbo plus fulvestrant or CAPI plus fulvestrant for PIK3 and PTEN mutation, and then ESR1, those patients can be potentially treated with elacestrant. In patients, when CAPI was added with fulvestrant, there was an improvement in progression-free survival. And then in patients with the AKT pathway, they have a substantial benefit by adding CAPI. There's an improvement in overall survival seen only in patients with an AKT pathway alteration. So the FDA approved it for patients with an AKT pathway alteration. ESR1 mutation is an acquired mutation in patients who are exposed to an aromatase inhibitor. Number of studies which looked at the progression-free survival and overall survival in tumors, patients with an ESR1 mutation, you can see a difference in progression-free survival and overall survival. The overall survival is pretty ominous, from almost 2 years versus a year if the patient has an ESR1 mutation. And this is consistent with a number of other studies published. Fortunately, we have a number of agents now which can target the ESR1 mutation, elacestrant, which showed a benefit and an improvement in progression survival, or subset of patients, especially patients with an ESR1 mutation. And FDA approved elacestrant for ESR1 mutated tumor based upon that. That's the first oral selective estrogen receptor modifier, which is FDA approved for metastatic breast cancer. So this is the next one, which is presented at San Antonio and published at the same time, EMBER-3, imlunestrant plus or minus abemaciclib was the standard of care endocrine treatment in patients with hormone receptor positive HER2 negative metastatic breast cancer. This one was imlunestrant by itself in patients with an ESR1 mutation. The progression-free survival substantially changed from about 4 months to 5.5 months with a p-value of 0.001. This is so imlunestrant plus abemaciclib. This one was imlunestrant by itself. Again, we can see a significant improvement in progression-free survival from 5.5 months to 9.4 months with the significant p-value. So an oral, next generation oral selective estrogen receptor or downregulator was added to a CDK4/6 inhibitor, abemaciclib. There was an improvement in progression-free survival in the intention to treat group. So if the patient has endocrine refractory disease, there are a number of other ADCs coming to the picture, TDXT, if the patient has IHC 1 plus or 2 plus, and then IHC 0, sacituzumab govitecan. Of course, the patients with BRCA mutation, we should think about a PARP inhibitor. And if they don't have any of those things, potentially looking for chemotherapy. And other agents which can be used with some of the biomarkers like MSI-High, entered, RET, and tumor mutational burden.
And I guess one of the things that is sort of leaps out is if you have a patient that has both an ESR mutation and a PI3 kinase mutation or some pathway abnormality, AKT pathway abnormality, how do you make a choice between the available agents today? So we have elacestrant, we have, capi, alpelisib, maybe we'll have, other agents coming forward. But in that circumstance, I'd sort of like to get your and Laura's take on how you make a decision in that circumstance.
It's tough, but also nice to have options. So I think, looking at the comorbidities, patient preference, discussion of the side effects, sequencing, thinking about what else you'd have kind of after, then integrating clinical trials. So, I think it hasn't been one size fits all, but it's hard to have a really clean approach either because, there's a lot of unique aspects, I think, to every patient case as well.
Jame, any other?
Yeah, fully agree. And again, as Dr. Spring said, so many choices. It's really amazing that we can potentially talk to patients about all these options. So again, as we always talk about metastatic breast cancer, of course, in a small subset of patients, we can potentially cure or give an overall survival, but quality of life is the most important thing we need to think. I think that will be one of the major discussion points, in addition to what Laura mentioned, what side effects, the age of the patients, potential complications with the previous regimens, then I'll pick an agent. I don't know what, Bill, how do you think?
I think it's, the luxury. In the past, it was like ignorance was bliss. We had a couple of drugs. We used them in sequence, and then we pivoted to chemotherapy and we called it a day, But now we have that many more choices and more that are coming. And I think we're going to have to really think through the options. But the nice thing is, I think the right choice and other trials have shown that you can really put off chemotherapy and you're not really compromising outcomes. So I think, the hope would be that we can, as Laura was mentioning, sequence these agents over time and maybe have a more prolonged period of time on endocrine therapy with targeted therapy before we have to go to chemotherapy. And the great thing is that there's so many other drugs that are coming along. We'll see how we decide to use them. Let me ask, quite frankly, I haven't put anybody off of a trial, the triplet with inavolisib yet, but I don't know if either one of you have, and this gets into the financial toxicity of some of our therapies. Has there been any pushback from insurance if either of you have put a patient on that regimen?
I have not yet put anyone on it, but I don't think not many have in the field yet. It's fairly new and, very specific patient population, but personally haven't heard of any specific insurance issues given the approval.
Yeah.
Besides the typical high copay potential, but in terms of flat out denial, I haven't heard of that.
So the same here, Bill. I guess I know it's in the NCCN, so that's a little easier for us to have that favorite pre-authorization code. But my colleagues have done that, and we didn't have issues within our team to get that insurance approved.
So one of the other questions that comes up, at least in my own mind, is when you start thinking, again, imlunestrant is not around yet. We don't have it approved. But, how might that be used? And in the context now that patients are getting more frequently adjuvant CDK4/6 inhibitors, that population in that trial had a relatively small fraction of such patients. How are you thinking about that data and that drug if that suddenly became approved? Laura?
Yeah, I think, the data with the doublet was obviously interesting. It wasn't limited to having, the mutation either. So I think we do still have the subset of patients that don't have ESR1, don't have PIK3CA, and then, you're going from typically first line doublet therapy, and then sometimes, considering single agent after that sometimes doesn't feel right. So I think that's one reason why this is intriguing to have another doublet option. But then, as you said, all these studies, just how it works, when trials happen, when other trials finish, approvals happen, we're going to have, a subset of patients who've already had adjuvant CDK4/6, as you said. And I think we're going to have to think about the timing, like, did this recurrence happen on it? What was the disease-free interval to help us make those decisions? And then, of course, even in the adjuvant setting now, there's 2 approved CDK4/6 inhibitors. Are we going to think a little bit differently about rotating agents? I think the algorithms in the field is going to continue to get much more complex, as we face this more.
Right. So, of course, Bill, I know you did so many studies with fast Redux from the beginning. So my question is how you're viewing fast Redux versus immunorestrant and in this subset of patients. Do you think this is going to be potentially the new standard? Or, of course, we don't have all the data really answering that. What do you think?
Well, I think that, the attraction is not only the clinical efficacy, but the oral administration of the drug. That as we all know, has been one of the limitations of fulvestrant. You can only inject so much into somebody's backside, and you're barely getting into the therapeutic range with what you can administer. So I think that, for certain patients, it is the appropriate drug because, they're getting it. But, for many patients, they would far more prefer taking a pill. And I think that's what makes it attractive. So I think the efficacy data and the administration route may indeed make it a better choice.
This next section will focus on managing the adverse events with CDK4/6 inhibitors. Let's just take a broader look at some of the key adverse events with CDK4/6 inhibitors. The first one we want to talk about is diarrhea. So we see this most with abemaciclib. So very important to educate and ensure patients have antidiarrheal therapy. Important to educate about increasing oral hydration and to reach out to their healthcare team early if this becomes an issue. Then often can benefit from dietary modifications, perhaps meeting with a nutritionist. In terms of hepatobiliary toxicity, we see this most with ribociclib followed by abemaciclib. And this is why we keep a close eye on the LFTs with the treatment. So we always get baseline and then essentially checking it every 2 weeks for the first 2 months and then monthly for a bit and as clinically indicated. Neutropenia we can see with all 3, typically the most with palbociclib and ribociclib, followed last by abemaciclib. And again, we're keeping a close eye on the CBC with differential. So always a baseline and then checking it twice a month for the first 2 cycles and then monthly for a bit and then clinically as indicated, with each of them having some slightly different instructions in the label for that. Then I think also important they are to educate patients if they're sick or to have a fever to certainly reach out to the team. Well, overall, the rates of febrile neutropenia with these agents are quite low. And the last 2 here are not common, but important to talk about. So VTE has been reported a bit more with abemaciclib. So important again to educate on the signs and symptoms of VTE so patients are aware. And then pneumonitis or ILD can be seen with any targeted therapy, of course, and including any of these agents, but overall rare. So again, important just to be assessing for that during the clinic visits as well. Here's some more specific guidance about managing hepatotoxicity with ribociclib. So as we reviewed before, important to get baseline LFTs and then checking every 2 weeks for the first 2 cycles, then typically the beginning of each subsequent 4 cycles after that. So basically in terms of thinking about the grading, it has to do with comparison to the upper limit of normal, which will vary institution to institution. So that's why you don't see the exact lab values. So grade 1 is upper limit of normal to 3 times the upper limit of normal. And at that, you can just monitor. You don't need to hold or have a dose adjustment. For grade 2, which is 3 to 5 times the upper limit of normal, that's where you hold until it resolves the baseline grade, and then you can resume at the same dose level. But if it recurs, you resume at the next lower level. And then when we get to grade 3, which is 5 to 20 times upper limit of normal, Again, you hold until it resolves to baseline grade, but then you always resume at the next lower level. If it recurs, you're permanently stopping it. And then for grade 4, it's permanently discontinued. And of course, importantly, in the early breast cancer setting, the dose is 400. So there's really one dose reduction compared to in the metastatic setting where you're starting at 600 and you have the 2 dose reductions. Then we want to talk a bit about just some expert recommendations for thinking about hepatotoxicity in early breast cancer. So in general, I think the field is being a bit more conservative in this setting. So, if someone has issues, it's more apt to maybe consider if they're also a candidate, say, for abemaciclib. And then we also find really that hepatotoxicity does not appear to be dose dependent. So often it could recur after dose reduction. And so I think in practice, we don't always go through all the dose reduction steps, especially if patients have other options. So next, let's just show you a bit specific about how to approach abemaciclib-induced diarrhea. So at a first sign of loose stools, the recommendation is to initiate antidiarrheals and increase oral fluid intake. So as you heard, that's why it's important to do that upfront education and make sure patients have these agents at home in advance. And in terms of the grading, so this is defined as how many stools over baseline. And understanding this requires some education too, so that way when your team is speaking with patients that they're able to kind of accurately determine what grade the diarrhea is. So grade 1 is 4 stools or less a day over baseline. And at that point, typically you're continuing abemaciclib using the antidiarrheals, but you're not having to adjust the dose. Grade 2 is 4 to 6 stools a day over baseline. And then there it depends on if it's going to, how quickly it resolves. So essentially you'd hold the dose until it resolves to grade 1 or less. And then, if it resolves quickly, no dose modification. But if it takes longer despite, appropriate supportive care, then the dose should be reduced. And the dose reductions are by 50 milligrams. So grade 3 would be 7 or more stools a day over baseline. And then grade 4 is life-threatening or urgent intervention indicated. There you're holding it till it resolves to grade 1 or less, and then do have the option to reduce the dose. And as I mentioned before, dietary modifications can be quite helpful. So often at our center, we will have patients with more significant issues with diarrhea meet with our nutrition team. So this kind of brings up the question, well, if we reduce the dose, what's going to happen to efficacy? And fortunately, when they looked at this, looking at the relative dose intensity, comparing the 3 different dose levels, that the efficacy still looked quite good, even when the dose had to be reduced. And this really mirrors what we've seen in the metastatic setting as well. So essentially, if a dose reduction is needed, I think, we should feel good about doing it, and hopefully it can help keep more patients on these agents. So in terms of general adherence to oral agents, we want to talk a bit about this. So it's obviously critical to reaching desired outcomes, both from a safety and efficacy standpoint. Many studies have looked at adherence to oral chemotherapy in general, and the range is quite broad, anywhere from 16% to some studies that show quite high adherence. In general, women demonstrate better adherence than men. And the reasons for poor adherence are many, including symptom-related distress, depression, dissatisfaction with clinical communication, and perceived burden to others. And we know that reduced adherence is directly linked to increased morbidity and mortality. So it's always important to assess adherence when we're following our patients to help identify barriers to adherence and help work together with them to successfully stay on these important agents. So in terms of optimizing patient education adherence, so some things we can think about: assessing readiness to receive information, when possible, ensuring another caregiver, another set of ears is present, setting expectations. So as you heard earlier from our panel, being really upfront with people that diarrhea is certainly a common side effect, for example, for abemaciclib, and really giving them some guidance on what to expect and some of the strategies that can be used. Also talking about duration of therapy, make sure they understand how long they will be on this treatment, pill burden, and what outcomes, what is really the benefit of these treatments that we are using. I think written information is helpful. Some might do pill container, medication calendar could help. And a lot of the packaging these agents come in, I think, is quite helpful as well, especially for ribociclib, where you're 3 weeks off, 1 week off. The packaging does help guide patients to remember that. Having trustworthy resources for reliable information is helpful. Identifying gaps in education, reiterating key information. Of course, working through financial concerns, even though these agents are, approved in the NCCN guidelines. Of course, some patients may still have a high copay, and important to ask about that. And, a lot of centers do have support staff to help in that area, which helps. Increasing pharmacist contact and visibility. So think in a lot of centers, pharmacists do help with the patient education for these oral agents, and then to developing a process for follow-up counseling shortly after the first treatment, especially as we heard with abemaciclib, for example, the diarrhea tends to be an early event, so having an early check-in can be quite helpful.
There's several questions that have come in, and sort of, taking a page from the neratinib, sort of evaluation of patients who have diarrhea, the dose escalation starting at a lower dose and then building up to the standard dose is one strategy that neratinib employed, and it seemed to be effective. We'll see how this trial turns out. But there were also other things that they had tried with neratinib, cholestyramine, colestipol. Are you aware of any data doing that from the get-go, above and beyond maybe providing patients with Imodium if they have diarrhea? Do you employ that at all?
Yeah, so I have tried it a bit, I think, in part because of the experience with neratinib. But with neratinib, they really did study those other strategies for reducing diarrhea in the control trial. So it's not something I commonly go to. I will consider Lomotil. Some patients have much more, impact with that. But I am very intrigued by the trade study, and I think starting low and going up, I think will hopefully be very helpful.
The issue with diarrhea is obviously disconcerting, but when you think about ribo, it's more the myelosuppression. Is there a level of myelosuppression or repetitiveness to it, at which point you would say, well, I'm not going to do this anymore? You would think about switching?
Yeah, I've had, compared to the metastatic setting, obviously with the approval of adjuvant abemaciclib happening earlier, I think we all have been, using that longer, of course. I'm finding after chemotherapy that I'm seeing much more neutropenia with abemaciclib than I do in the advanced breast cancer setting. And then, alternatively, though, we're starting someone on ribociclib, you look at the numbers, and of course, neutropenia is less with abemaciclib. So I do think that is a strategy that you could switch from one to the other. But I do have someone right now who even though they're having neutropenia on abemaciclib, we're on the lowest dose, and it's not like, ANC of 900, it's like ANC of 600. So even though, on paper, ribociclib, is higher rates of neutropenia, we're actually just going to try switching because, we've tried to do what we can with the abemaciclib. So again, it comes back to, I think, that it's nice that we have two options for many patients.
Let me ask you a question, Jame, and I'm not sure I have the answer, so hopefully you do. But have you tried using N-acetylcysteine for minimizing hepatotoxicity, or for that matter, if you're convinced hepatotoxicity is related to a CDK4/6, even steroids?
Right. So I'll say I haven't used N-acetylcysteine, but let me say about a patient. And I had a patient who was like T4, stage 4. She had a fairly large breast lesion, and then she had a sternal lesion. I put her on ribociclib and letrozole de novo. She was doing well for 6 to 8 months, and then she started having her LFTs going up. Really, 800, 1,000. Then I stopped the ribociclib, and it kept going up, and then it came down after some time by itself. I kept her on ribociclib, and then eventually she went for surgery because she had nice response, and it's oligometastatic. Then I put her on palbociclib, so I didn't do it. Her LFTs came back completely normal, put her on palbociclib, and she's doing well. She's almost a year on palbo with no change in her LFTs.
Okay, so in that particular patient, are you sort of thinking that is pseudo-adjuvant therapy, or what, in a sense, because I guess she had oligometastatic disease, right?
Right. So pseudo-neoadjuvant, now she's kind of, pseudo-adjuvant treatment. Yeah. And she's 78, and I'm not planning to do any chemo. And she responded nicely to the neoadjuvant and this treatment. I didn't use steroid. I was almost I did ultrasound of the liver, sent her to a hepatologist, but they didn't have anything else to add. They didn't add steroid to it. So it came down nicely by itself.
There was a question that I meant to ask on the last session that I didn't get an opportunity to, which is a little bit tangential to the topic we're talking about now. But if you have these patients that are both ER positive and HER2 positive, Is there any circumstance where you would employ a CD4/6 inhibitor and HER2-directed therapy concurrently? Laura, I don't know if you want to.
So I've only done it on trials so far. And then, of course, we saw the presentation of the Patina study at San Antonio, which I think, had some pretty impressive results. But I do think that's where, at least, currently where it's not in the guidelines, not approved, I think, you could definitely have insurance challenges there because you're going to be asking for, 2 oral agents potentially, or, even oral IV. And, usually the requirement for the CDK4/6 is HER2 negative in terms of, what insurance might be looking at. So I haven't done it off study.
How about you, Jane?
So that's interesting you're asking that question. So as Laura said, Patina numbers are pretty impressive. Cleopatra is the holy grail, and none of the trials. We'll see what's going to happen with TDXT in that first line setting. So far, THP is the gold standard. And so the question is, should we do CDK4/6 in the maintenance setting? And the data is really impressive. So how that's going to translate into early stage, I think, and I'd be really interested in knowing that.
Yeah, I agree. I think that data was pretty compelling. So there may be circumstances where we use it, particularly if it finds its way under the guidelines. Any other thoughts on other unusual side effects that you've experienced in these patients? What's your own experience just in terms of adherence, particularly in the adjuvant setting at 2 and 3 years, depending on the drug you're using? Have you had any issues with patients remaining compliant?
I find patients, especially, those with high-risk disease tend to be very motivated. So certainly the dose reductions have helped, but I've had, now a decent number of patients complete the 2 years of abemaciclib. They're certainly happy when they're off it. And, usually as we discussed, the diarrhea sort of gets under control. It's the fatigue in part is why I find, patients are so happy when they're finishing it. But I think, I've had some others more intermediate risks or maybe low and intermediate risk where you may not feel strongly about this. And, as they consider risk benefit, that's, I think, the population that's, for me, has been more apt to stop adjuvant CDK4/6.
Yeah, I don't think I've had anybody at 3 years on ribo yet, so I don't know that. How about you, Jame? Any different experience?
So I'm curious to know what Laura thinks. And I had some patients with rash, and again, not in adjuvant, but in metastatic setting on ribociclib. And sometimes the rash is pretty impressive. And so have you seen and how you manage those kind of patients?
Yeah, I've seen some interesting rashes on it, like not always the typical distributions, but I haven't had anyone have to stop over rash. I have seen, we talk about neratinib a bit. Certainly have seen some pretty bad ones on that. Lisib, so they haven't been as bad as those rashes, and we've used more topical steroids for them.
There's a case that came in that I'll just describe briefly. 65-year-old woman who was diagnosed with bone mets while on the 3rd year of adjuvant anastrozole. And when they did NGS, she was found to have an ESR mutation. She had already started on fulvestrant and ribo. So now, sort of after the fact, after they pulled the trigger on fulvestrant and ribo, they know she's got an ESR mutation. So the question then that's posed is whether it's reasonable to continue with what she's on, or would you pivot to elacestrant?
So this is an interesting case, right? Because, while it can happen, we don't often find ESR1 at time of recurrence on adjuvant AI. Typically, it's when you're on AI for a while in the metastatic setting. But of course, there is, a small percentage of cases like this that we see. And I think the other interesting aspect is to think about, well, what type of ESR1 mutation is it? Because I think there was evidence that fulvestrant, still do a pretty decent job with some of the ESR1 mutations. Then, of course, they're on doublet therapy with the fulvestrant and the ribociclib as well. So versus elacestrant would be single agent, and that's in part what we were discussing a bit with imlunestrant and abema, the appeal of, having dual therapy. But I think I would keep them on, fulvestrant and ribociclib, and, of course, just keep an eye on things.
Jame?
Yeah, I agree, though. In addition to what Laura said, at this point, we want to get the maximum out of this regimen. So I'll keep the patient on the same regimen, continue to monitor depending upon the response. Then we can decide if we should change to something different.
Thank you, Dr. Abrahams, Gradishar, and Spring for an interesting presentation and discussion, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, experts debate and discuss therapeutic strategies using CDK4/6 inhibitors across breast cancer, please click the link in the show notes. And be sure to check back for more episodes on important oncology topics.